Good morning. I'm Michelle Lavander, Director of the Center for Health Journalism. Thanks so much for joining us today for our Health Matters webinar, America's High Maternal Mortality and What Can Be Done, offered thanks to a generous grant from the National Institute of Healthcare Management Foundation. We'll take for our point of departure research by our first speaker today, Eugene DeClercq, a professor at the Boston University School of Public Health. He found that the maternal mortality rate increased by more than 26% from 2000 to 2014. This gives the U.S. the unique distinction of having the worst maternal mortality outcomes of any developed nation. And as Nina Martin, a reporter at ProPublica, found, it's a problem that's largely invisible because of privacy laws, poor data keeping, and how we talk about birth and death as a nation. Her series, Lost Mothers, put this issue on the front burner by bringing the stories of these women to life and investigating the medical shortcomings that led to their deaths. Finally, Dr. Elliot Main, Medical Director of the California Maternal Quality Care Collaborative, will share steps that California took to bring about dramatic improvements and the work he's doing now to spread these lessons nationwide. Before we get started, I want to share a few operating procedures. We'll hear first from all of our speakers. Then we'll open it up to your questions for the final 20 minutes. Because we have several hundred people participating in the webinar, we'll ask you to comment in the question field in your control panel, and we'll read out your questions. If you have technical challenges, please also text us through the question or comment field in your control panel. You can also tweet about this webinar at the hashtag maternal mortality. We're going to get started with Professor Eugene DeClercq. Gene, you are one of our country's foremost experts on maternal mortality. Let's start off with the basics. What does maternal mortality mean, and how bad are the numbers?
So hopefully we're pulling up my slides. I see them if nobody else does. Hang on. There. Let me take you through some of the data on this and try to address your question as well as I can in the brief time we have. First, some definitions. Can everybody see that? Is that showing up, hopefully? I'm not going to go through this in detail, but I'll just note that for international comparisons, people use the maternal mortality ratio, which is the death of a woman while pregnant or within 42 days of the termination of her pregnancy, particularly if it has to be related to or aggravated by the pregnancy. I cite that because I just contrast it with pregnancy-related death, which is a measure we use in the United States. There's some different language internationally. It's essentially the same measure, only it goes out to 1 year. So you have two measures that are out there. One that looks at deaths during pregnancy, birth, or up to 42 days after, and a second that looks at it up to 1 year. There's also pregnancy-associated death, which is simply a time function, the death of a woman while pregnant or within 1 year of termination, whether or not it was related to the pregnancy. So what does it look like? And my slide isn't changing. Here we go. So is there a problem in the United States? Yes, and so I think I'm done now, and we can, I guess I'll keep going on that. This is the maternal mortality rate in the United States over the last 60 plus years. And you can see there's three real periods here. The first is this period from the 50s to the 80s, where there was a substantial decline, almost a 90% decline, from around 75 per 100,000 live births to about 8 per 100,000 births. You see the period from 82 to about 98, almost 20 years, basically no change, a slight decline, but basically no change for about 20 years. And then remarkably, you see this period when the rate starts to go up between 97 and 2007. The other striking piece in all of this is, why is it ending in 2007? The U.S. National Centers for Health Statistics have not reported a maternal mortality rate since 2007. And so the question is there any more recent measure we can use to give us a more timely sense of the maternal mortality rate in the United States? And it turns out there is. It's from the CDC. They do a wholly separate measure, and I can talk about this if anybody's interested, but they have a wholly separate measurement system that looks at pregnancy-related mortality. And here's the data that they publish showing the pregnancy-related. Again, that's simply the same measure as maternal mortality, only extending it out to 1 year. and a substantial rise over time, over the last 25 years, from around 7 to 9 per 100,000 to around 17 per 100,000 in that period. But this measure, while useful in the United States, doesn't let us do comparisons with other countries. So what can we do about that? How can we compare that? Well, some colleagues and I did research on just that question, where we tried to identify recent increases using the National Center for Health Statistics data. And it's very much a methodological article, and I won't go into the details on it because it's kind of a snoozer, but let me note this. Again, there we go. In our estimate, using the national data, we found a 27% increase, which is actually a smaller increase than the one you see for the pregnancy-related mortality rate, but that's only because in this period of time, we were reporting a higher rate than they were. Having said all of that, I would put more faith in their measure than ours for technical reasons, in terms of what we found in our article was some real problems with the measurement at the moment. So given this, how would the United States compare internationally? Using the measure we had, this is how we would fare against all other countries in the OECD, essentially industrialized countries. And obviously we fare far worse than those countries. I don't think we say, gee, if we can only get close to Chile and Turkey, we will be satisfied in terms of health outcomes in the United States. Let's use a more conservative measure. You can use the pregnancy-related mortality measure to come up with I think a little bit more precise measure. And this would be, if someone asks me, this would be the rate I would use, that for the period of 2011 to 2013, it was probably around 15 per 100,000. And you can see striking disparities by race ethnicity, that for non-Hispanic white women, about 11, for non-Hispanic black women, 36, for Hispanic women, 10. So the black-white disparity is about 3.2 in their measure. Now, this is a historic fact. This disparity is carried on for some time. If we look at it going back to the 50s, the blue line represents the maternal mortality rate for black mothers, the red line for white mothers, and the black line is the overall rate. And what you can see is the disparities have decreased, but they're still pronounced. And in fact, from the period of about 87 to about 97, they were the lowest they've been, but still pretty miserable, and increasing in more recent years. So let's look at just that ratio of black to white maternal mortality. And what you see is ranging from 3 to 4 times. In other words, the likelihood of a non-Hispanic black woman dying during the periods we've defined is about 3 to 4 times higher than it is for a white woman in that period of time. Now, to give this some context, we've long talked about the disparities in infant mortality in the United States, and those are pronounced. But for comparison purposes, the red line represents infant mortality, the disparities between black and white infant mortality, and they're pronounced and they're depressing at about 2.2 or 2.3 times higher that a black infant will die in the first year of life than a white infant will. But that pales in comparison to the disparities between black and white mothers dying. So the question that rises, why is the disparity greater for maternal mortality than it is for infant mortality? Well, let's use that more conservative measure in an international comparison and start to get to a little closer to that. So remember that figure was 14.8. If we use that in terms of the US maternal mortality rate, what you see is compared to other industrialized countries, and in particular, industrialized countries with at least 300,000 births, which is a better comparison than really small countries. What you see is the United States is last. But what's really striking, because you look at that and one assumption is that that must be a function of the disparities that we were talking about. But the next slide puts the lie to that. If we limited the US ratio to just white mothers, they would still rank last. US would still rank last compared to other large industrialized countries. Where would that leave us in comparisons? Well, that Hispanic rate of 10.0 would put us between Lithuania and Portugal. The non-Hispanic white rate would put us between Bulgaria and South Korea, and the black rate puts us between Uzbekistan and Mexico. Again, countries we generally don't claim as comparator countries in terms of US health outcomes. So, if even by a conservative standard the US fares poorly in international comparisons, the question is, what can be done? The key is going to be a combined clinical, public health, and policy response. Now, Elliot Main's one of the leaders nationally around the both the clinical and the public health, but in particular the clinical one, and he'll be talking about that a little bit later. So I'm going to focus on the public health and policy response. Why do you need a public health response? I think this is a very important pie chart, and I'm not a big guy on pie charts, but I think it's important. If you look at it, it breaks down when women who died in maternal deaths, when did they die? And what you can see is on the lower right, about 17% died on the day of delivery. Next to that in gray, 1 to 6 days. So overall, about a third, a little more than a third of the deaths actually occur at delivery or in the first 6 days afterward. What you also see is that about 31% died before delivery during pregnancy, and roughly a third died between 7 days and a year after the birth. So what that suggests to us is that if we only focus on pregnancy, we might have some difficulties in resolving the issues around maternal mortality. So what's the policy response that's needed? Investment in public health infrastructure. We still don't have a very good handle on just who is dying, when they're dying, and how they're dying, and we still need to refine that considerably. We still need to have an actual maternal mortality rate for the country. But more importantly, we need to have an investment in women's health when they're not pregnant. I go back to this slide. Part of what happens here is we invest in women when they're pregnant, and that's part of the reason why the disparity, as bad as it is in infant mortality, is not worse. And the fact that we don't invest in women's health when they're not pregnant is part of the reason why the maternal mortality is both more problematic and has greater disparities. To give you a couple of quick examples before I finish, one involves a level of coverage. So this is variation in Medicaid eligibility by pregnancy status. This is from the Kaiser Foundation. And you see the US average for Medicaid eligibility. When a woman is pregnant, she's covered if she's within 203% of the poverty level. If she's not pregnant, a mother with a family of 3, a mother in that situation, it's 107% of the poverty level. And you see some selected states and the disparity between states. In some cases, not substantial. In most cases, pretty good. And in a few cases, Alabama, Texas sort of stand out in this. Huge differences, which means essentially that women will not be covered when they're not pregnant and will get coverage only when they're pregnant. And that's manifested in this chart from an excellent piece that was in Health Affairs. And I would encourage people to take a look at that. They looked at, in a period that was pre the ACA for the most part, at when women had coverage and when they didn't. And the sort of teal line is women with no insurance. And if you follow that along, you can see that prior to pregnancy, about 24% had no insurance. And then once you hit the period of pregnancy, it starts to go down because they can get coverage in a lot of those states. And it gets down to about 11% at the time of birth. And then you see after the birth starts to rise because women are dropped from coverage in many states as early as 6 weeks afterwards, up to 6 months afterwards, and they start to lose their coverage. Medicaid coverage increases and then drops dramatically. I think this circle is a critical piece in understanding what's happening in terms of maternal mortality. If we only deal with women notice this entire period is what we're talking about in maternal mortality, but if we're only really focusing on their health from here to here, the message that's being sent is it's only about the baby and not about their own health. So the other piece to understand is maternal mortality is simply the tip of the iceberg on women's health. If you look at the health of women between 15 and 49, which we generally use as reproductive age, maternal deaths account for about 1% of all the deaths to women 15 to 49 in the United States. And what's notable is if you look at it over time, which I do for fun, sadly, the death rate for women between 15 and 49 has been essentially stable since 2000, has not improved. It's improved some for younger women. It hasn't improved at all for women between 25 and 49. So focusing only on pregnancy won't solve the problem of maternal mortality in the United States. This is where you can get more information on this. It's a site I do with students. Those are the students. I'm the guy in the yellow. I'll be glad to answer questions later after you hear the other two excellent talks you're about to hear. Thank you.
Hello. Hi, this is Nina Martin. I'm not sure if you can hear me.
It's any consolation, I can hear you.
Okay, good. I just made my screen big, so. Hello, this is Nina Martin from ProPublica. Can people hear me?
Yes, you're good. I can see your screen.
Okay, great. Well, thank you for having me. So I am a reporter at ProPublica, where I cover sex and gender issues. And I have a long-time interest in pregnancy and maternal health, a professional interest. I also have a personal interest in the particular topic that we're talking about now. My sister nearly died after giving birth in Texas in 2000. She nearly died in the postpartum period. And so as I was listening to Dr. DeClerc's excellent presentation, I was reminded of the data and how it has always really intrigued me, the data around recent data around maternal mortality and morbidity. It also, I was also intrigued by the possibility and the importance I felt of extending the conversation about women's health and women's reproductive health beyond abortion and family planning, where it has often rested over the last few years. And so that was kind of one of the goals that animated my interest, these goals in this topic. But I didn't, so I was very interested in maternal mortality, but I was not having some problems with my slide here. I'm having trouble moving. Okay, but I wasn't, there we go. I wasn't interested in, I didn't want to start with maternal mortality. I decided that I wanted to start with near misses for one of the reasons that Dr. DeClerc suggested, because maternal mortality numbers are actually really pretty small, and they're only the tip of the iceberg. The real big numbers looking at maternal complications are in the near misses. And I felt pretty strongly that I also wanted to speak with women, and I wanted to let them speak for themselves. I knew from my experiences with my sister and other women that they felt really dismissed and silenced, and I felt it was really important to understand what they'd gone through and to learn. I thought we could learn a lot about the circumstances around why women died by listening to the women who had nearly died. And finally, I had talked to enough researchers to know that they actually have a lot of restrictions about talking to patients, women, and also how that information can be used sometimes and how quickly it can be used. And journalists, obviously, we have our own very strong code of ethics, but we can kind of go where many researchers hadn't been able to go. So first, I reached out to maternal health organizations, and we conducted long interviews with 30 plus near-miss survivors. We also did targeted outreach to African-American women mostly on Facebook, because we knew from the beginning that we would have a difficult time reaching them, and we really wanted to include them in our background research on this topic. And then, of course, we also talked with researchers, clinicians, and other experts. Here's a list of the patient advocacy resources that we used, and if you have any others, we can update this. Please send them to me at the address below. So that was the first thing. Then after doing that research, we decided it was time to start putting a face to maternal mortality. And so I started doing what reporters often do. I started with Nexus and Google. And the first surprise was that I found very few deaths on Nexus and Google. I found that obituaries rarely mention cause of death. I sort of came to see in my conversations and my reading that families are actually conditioned to see maternal deaths as private tragedies. And this kind of lets hospitals, regulators, and policymakers, and the public act as if there isn't a problem with maternal mortality or severe morbidity. The second surprise was that the deaths that we did find often didn't fit the stereotype. The stereotype was that we would find low-income women of color mostly, who had poor insurance, who were in bad health, who basically, lived in areas where there was no health care, and I was finding nurses. I found, the spokeswoman for Yellowstone National Park. Perhaps the most surprising of the deaths we found was a woman named Lauren Bloomstein, who was a NICU nurse in New Jersey, very healthy, very middle class, married to a doctor, who had died at the hospital where she worked, even though she went in apparently very good health. And that sort of became the defining question as we thought about this whole project, putting a face to maternal deaths. If somebody like Lauren Bloomstein could die, what did that tell us about what was really what were the other issues with the maternal care system in this country that maybe weren't being addressed by journalists or others? The key insights. First of all, as Dr. DeClercq has already said, the medical system, it turns out, is often much more focused on babies' health and safety than on moms. This is from the beginning of the process, and from research to Medicaid and everything in between. We found, as Dr. Main will talk about, there were a lack of protocols and standards in treating obstetric emergencies, and that this was often a major factor in many maternal deaths and near deaths. We found that these were systemic problems that endanger not just some women, but all women, and that can you hear me?
Yes.
Yes, we can hear you now.
Okay, good. Okay, good. Okay, good. And that these systemic problems endanger not just some women, but all women, and that because maternal deaths are almost invisible, and not just the fact of the women who died and how, but the details of how they died, the details of their families, the details of their interactions with the medical care system and other important support systems in their communities. The lessons are lost. So the question was, how do we find these women if they're invisible? And then we had this aha moment as I was going through some of the stories that I did see. And the aha moment was that most families these days, as you can see right here, many families use crowdfunding sites to honor loved ones. So it occurred to me that crowdfunding sites could be a great source for researchers. So here's a slide that shows two searches I did recently on GoFundMe. That's the major crowdfunding source site that I've used. I have to warn you, crowdfunding sites are not meant for this purpose. And so the search function basically is terrible. They're hard to scroll. The campaigns are not organized in any order. You have to be persistent, patient. You have to have a really high threshold for misery because the stories you find are really sad, but it turned out to be a really invaluable source for us. Here's an example of what we did. We would find a name on one of the searches that I just showed you. Here's a woman who died just this past year, very sadly. And then, so that we would find a little bit of information, including her name, and then we would do a search for her obituary and pull up a lot more information to try to confirm some of the details of her death. Another really important tool that is available mostly for journalists, I think, is something called Facebook Signal that allows you to search public posts over a period of time. It again is a highly, it's free. You can just ask Facebook. It takes a little while to get set up, but they'll set it up for you if you're a journalist. It is highly imperfect, but again, it's great for, especially for keeping track of recent deaths. And here's an example of how we used it. Here's a search that I did using the keywords passed away, giving birth. I turned up this woman, Tabitha Baxley, just a name from a friend, and then we were able to go and find Tabitha's obituary. And as you'll see, it has a lot more information in it, which, but it does not, her obituary does not include the fact that she had just given birth. So we would have missed that. That's one of the ways that otherwise you would normally miss those kinds of cases. To fill in the gaps, we did something that any journalist could do, which was we asked our community for help. And so in this case, ProPublica has been working with National Public Radio on this project. We put together a call out, which we launched in February. In fact, the weekend that we launched, by the end of the weekend, we had 2,500 stories. Since then, we are now up to 5,000, and it's, I think, a sign of the power of NPR, but also a sign of how much people really wanted to talk about this topic. Here's what we found: 160 plus lost mothers in 2016 alone. This is just a part of what lives on my Google Drive for those women. These pictures are all from GoFundMe, from public places, sometimes LinkedIn, sometimes obituaries. And then came the really hard part, which was persuading loved ones to tell you their stories, their family stories. What we discovered was that there's just a lot of sensitivities around maternal death that surprised us a little bit, and that we've come up against again and again. The big ones are, there's just these are incredibly traumatic events for families. That when we were reaching out to people fairly recently after their loved ones had died, but we were reaching them, we'd found them on social media, and there was a little bit of suspicion about that. And then as we sort of probed things, we realized that there's just a lot of sensitivities, and sometimes it's guilt, sometimes there's family conflicts. Sometimes the family doesn't know what happened, or they don't want to see what happened to their family member as a problem, if it was a problem, because they see the hospital as staff as heroes. And then we also discovered that Black families in particular are really sensitive, talking about issues around disparities in race, and that those conversations have to be approached with great care. So here's what we ended up publishing. 120 names after our fact checking, after verification, and 51 photos. Today, I think we just updated it, so we're up to 134 names and 50 photos. And we decided that we wanted family permission to use any photos, even photos that had been used on GoFundMe or in obituaries, because we wanted family members to know what we were doing. What we were doing was so unusual, and we just wanted their buy-in, basically. We could have published a lot more photos, as you saw, but this is what we decided to do. So, part 4, what did we learn from the lost mothers? As Dr. DeClercq has already said, we verified what they found is that postpartum deaths and fatalities are very common. We saw a lot of mental health issues. We saw many, many, many preventable deaths. We found that often families never find out what happened, which is really sad and painful for them. We also found that when a mother dies, multiple lives are crushed. Entire family systems are destroyed, and that's often not recognized or acknowledged. Here are the women that we found, we wrote obits about for our Lost Mothers gallery that we posted in July. The thing that strikes me about these women as I look at these photos is that they are, everyone is different, every story is different, and yet they're all the same. You can't tell who's on Medicaid, who got pregnant accidentally, who was a drug addict, who had mental health issues, who died of a preventable hemorrhage or sepsis or heart problem. You just see women, and I think that that's really important as you think about maternal mortality and particularly severe morbidity in this country. We're talking about every woman. We're not talking about people who are sort of marginalized only. We're talking about everyone. Some lessons. I won't go through these. I'm running out of time here. The most important ones are These maternal deaths are not human interest stories. They're really a public health issue, and I think we should try to think about them in that way, and also not think about them as kind of just an anecdotal lead to another story. You lose a lot of the nuance that if you do that, and the truth of the story that is really important to understand if you want to write about maternal deaths in a real way. You've got to work really hard to include women of color, and you have to give them extra time to kind of come along and build trust. You need to really focus on postpartum care, I think, and to understand the sensitivities. And lastly, I would say that when reporting about maternal deaths, it's really in your community, really kind of look also for the near misses, because maternal deaths, as we said, are just the tip of the iceberg, and you really want to be understanding the iceberg. So that's it. Thank you.
Thank you so much, Nina. We're going to turn to Dr. Main right now. And Dr. Main, what can be done? Is there a way for America to lower its maternal mortality rate and prevent these deaths?
Thank you, Michelle. We do have opportunities, and I'm going to use California as a jumping off spot and then really look at the U.S. as a whole as to what can be done.
Dr. Main, you need to accept.
We're good. But now, there we go. So California is the largest U.S. state with over 500,000 annual births, 1/8 of all the births in the United States. And the red and blue lines show the trends that we were detecting in California. California is in blue. And we kind of followed the U.S. as a whole with maternal mortality rates. As Jean was saying, this is one of the measures that we were using. In 2006, the Department of Public Health noted that we were rising, and that was a consistent rise, and set up the very first maternal mortality review committee for the state of California. And I was honored to chair that. And we wanted to do this a bit differently, not just to look at the epidemiology, the numbers, but to really look at what were the quality improvement opportunities expressed by these deaths, i.e. what could we do to improve the outcomes. So the California Maternal Quality Care Collaboratives was started at the same time as an action arm for improving maternity outcomes. We've talked about some of the difficulties with the numbers back and forth, and there's clearly a rise, but people have argued about just how much the rise is because we're dealing with small numbers. When you look, though, at other independent measures, here the CDC measures severe maternal morbidity, you see in the same time period also a twofold increase. So the rise has been not only in maternal deaths, but in near misses and in particularly severe morbidities, which is a step down. And what you see here is maternal mortalities are 1 to 2 per 10,000. ICU admissions, which is a pretty good marker for the near misses that Nina was talking about, it's tenfold higher, 1 to 2 per 1,000 births. And severe maternal morbidity, the way the CDC defines it, includes hysterectomies from hemorrhage, major complications, and also transfusions. That's 1 to 2 per 100, or 1 to 2%. When you look at the causes of maternal mortality that occur in this time period of maternal mortality, you could see that there's venous thromboembolism, infection, hemorrhage, and preeclampsia all count for 10 or 15% of the deaths. Cardiac disease of all forms is 25%. But as you start moving towards severe maternal morbidity, hemorrhage and preeclampsia account for the lion's share of deaths. Also, when you look at preventability, these are 3 independent reviews. Ours is in the middle in California, where we had good or strong chance to alter outcome. The major preventable causes are hemorrhage and preeclampsia. Up to as high as 70 to 90% of those deaths are preventable, whereas some of the other causes are somewhat less. So we started off focusing on hemorrhage and preeclampsia because it was the most common preventable causes of maternal death, far and away the most common causes of severe maternal morbidity, and had high rates of provider quality improvement opportunities, largely summarized by denial and delay. this is a frame that I like to use. This is an article in Vox talking about some of the things we did in California, and our committee reviewed several hundred maternal deaths. That's actually hard work to go through and hear the stories, go through the stories, and realize that at least overall half the deaths were preventable. And that really spurred us. We were tired of seeing maternal deaths and really wanted to do something about it. So our approach in California was to really put together as large a consortium as we could. CMQCC pulled together professional organizations, the doctors, the nurses, the midwives, anesthesiologists, everyone we could find, and bonded with our Department of Public Health, the Hospital Association, a key partner in this process, as well as our Medicaid program. In addition, we partnered with anybody and everyone we could find, including risk managers, just large, everyone. We did multidisciplinary approaches to hemorrhage and preeclampsia, forming toolkits and then collaboratives, starting as early as 2009, and then spreading these out with quality and safety initiatives through more and more hospitals over the next stages, so that we've reached over 200 of the 230 hospitals in California for hemorrhage and preeclampsia, and now we're working on cardiovascular disease. This same time period, we've seen a marked decline in maternal mortality in California as opposed to the United States. Many factors can go into a change in public health measures, but the women in California are not getting thinner, they're not getting younger, they're not getting less diabetes and hypertension. We think that the focus on safety has been a significant contributor here. So now we're seeing what can we do to push this out in a more national way. And with the Maternal Child Health Bureau at HRSA, with funding to the Council on Patient Safety, which is based at ACOG, we've been working on this in multiple states. Again, we're trying to partner with as many people as we can, including every professional organization, public health organization that we can find, together with quality improvement organizations and patient-centered folks such as the Preeclampsia Foundation. The goal of this project is to prevent 1,000 maternal deaths, prevent 10,000 severe complications through the adoption of national patient safety bundles to improve quality and safety at the hospital level and during prenatal care. Through working largely through perinatal quality collaboratives at the state level to have their partnerships built up that mirror what's going on nationally and what we did in California. So what is a maternal safety bundle? It's really a checklist of items and practices that we expect every birthing facility to have, whether it's small or even a birthing center, up to a tertiary center that may have 5,000 or 6,000 births. It's not a national protocol. Obviously, resources vary from site to site. Facilities will need to modify how they do it based on local resources, but it does have very strong guidelines and recommendations for every unit, for preparation, for every patient when they come in, and for every hemorrhage or every preeclamptic episode, and then how to learn from cases. These are all open source, available at safehealthcareforeverywoman.org. The key safety bundles are in the pink box here: hemorrhage, hypertension, venous thromboembolism prevention, blood clots, and the safe reduction of primary cesarean births. We've seen a 50% increase in cesarean rates in the same time period, and the consequences of cesarean are often in the next pregnancy. Just released bundle is a very important one, and that's the obstetric care of women with opioid dependency. There are supporting bundles in the bottom half, including a very important one that Nina touched on, which is the need for patient and family and staff support for the near misses as well as for the catastrophic cases. There are resources in each of these bundles to help hospitals and physicians work to achieve these goals. So where are we? This slide is where we were with AIM in July. There were 11 states enrolled. Is shown in dark green with an impact potential of 1.5 million of the 4 million births in the United States. There were another 21 states that were quite interested and came to our national meeting in April. And it's interesting now, just in the last 2 months, 10 more of these states have joined AIM. So now we have 21 states in AIM. The bundle on opioid care is one of the striking needs that is emerging as a key cause of maternal death, unfortunately. So we have the AIM project, which is funded by Maternal Child Health Bureau and HRSA. Obviously, we need more money as now we're doubling the number of states coming in. The CDC has released money for state perinatal quality collaboratives to help set up the infrastructure in states to do these kinds of projects. And the MARIA project, which is for maternal mortality review committees. There's many of our states are way behind in understanding what's going on locally in their states. In Congress, there are bills being proposed to support maternal mortality review committees. These are in committees currently with some bipartisan support, but Congress seems to be preoccupied with other activities currently. We're also working with state Medicaid programs. They pay for half the births in the United States, and they have serious skin in the game. And we are talking with foundations to support these efforts. This is our core group at CMQCC. But the strength of our organization is the ability to partner with many other organizations to get it done. No one group, whether it's the physicians or the hospitals or the health department, can do this alone. So really the key is putting everyone together with some common goals. So I'm going to end now, and I think we're going to open it up to questions. So you can take the slides back.
Great. Thank you so much, Dr. Main, and to all three of you. We are going to open it up to questions. You can all see that there's in your control panel, a little question field, and you can type in questions for any of our speakers. I'm going to start out with one that was sent earlier from Robin Fink, who says, for local health reporters, what would you look for in partnerships, help accessing more information or advocacy from public health researchers and practitioners in working toward generating more comprehensive stories? Nina, do you want to take that?
Can you hear me? I'm sorry. Yes, I realized I was on mute. I apologize. So I think that one of the places I've started that I have found to be really useful are locally, if you live in a state that has a state maternal mortality review committee. Those, not every state does, but there are many people on those committees who are deeply interested and committed to this issue, and who understand a lot about how things work in the state and the area that they work in, both sort of the politics of it, and just the literal, the numbers, the politics, what information they have, what information they don't have. And every time I have a conversation with somebody who works at one of these committees, I learn so much. So I would say that. I would also say, I think that, locally, there are many, I found that nurses are really great sources of information. I think nurses, get a lot of, don't get enough credit from, and maybe a little bit for the work that they do and especially when things go wrong, but they have a huge interest in caring for patients and really understand, again, how systems are. And they're often easier to reach than doctors and kind of see things that a lot of the doctors and hospitals may not see.
As the chair of a large maternal mortality review committee, I think one of our limitations is that in most every state, our cases that we review are de-identified, i.e., I don't know the name. I don't even I don't even know the name of the hospital when I'm reviewing cases.
Right.
So that's obviously limited when you want to put a face on a story. So I think we can give background, but we're not going to be able to introduce you to cases, to women and families themselves.
Yes, I should have said that. I meant as background, not as primary sources for cases.
And we have a question from Tanya Lee, who says, can you speak to maternal mortality in American Indian and Alaska Native populations?
Dr. DeClercq, have you done
I don't have data on that, so I can't.
Yeah. There's,
so
go ahead.
We do have morbidity data. The populations are quite a bit smaller than the other subpopulations by race. And we do know that the maternal mortality rates are higher, the maternal morbidity rates are higher, but it's harder to get more accurate numbers because of the small overall size of the population, but it's going to be close to the African American rates, all the numbers I've seen.
We had in our Lost Mothers Gallery a woman who died who was Native American from Minnesota, I believe. And so I think that we also have a sense that we don't really have lots of deaths haven't come to us, but in our call out, we have been surprised at the number of stories we've gotten from women who nearly died, who were who were Native American. It was the proportion we got of those stories is far higher than of African American women who've responded.
We have a question from Elise Wong, who says, could you talk a little bit more about the relationship between opioids and maternal mortality?
It seems like the opioid epidemic is affecting all parts of the health of Americans, including now maternity care and childbirth and maternal mortality. The numbers are emerging. As you've seen, the national numbers are multiple years behind, and the opioid epidemic is on us right now. So we don't have national numbers on it, but some of the states are seeing significant proportions of their deaths, maternal deaths, now being due to substance use and overdoses. So that has raised the flag for many state agencies, as well as obviously neonatal withdrawal, which is a hugely costly event. So there's a renewed focus now on upstream, i.e., first, what can we do with mothers during pregnancy, but even further upstream, what can we do with women to give them better care prior to pregnancy? There are several different levels of prevention, and Jean was talking about systematic improvements in women's health. I was talking more focused on care during pregnancy and delivery. But then there has to be a handoff afterwards, and this is a big issue with opioids. There's typically a lot of supports during pregnancy, and then that care can end at 6 weeks, and then what happens to the mother next? So these are all emerging as issues.
If I could just note, I'm on the Massachusetts Maternal Mortality Review Committee, and I'm not a clinician, so I get the non-clinical cases, and a number of those will be opioid cases. And there's two other things to keep in mind. Oftentimes, opioid use is comorbid with mental health issues, and our mental health support systems aren't particularly great. And again, you see that drop off afterwards. But you have a particular challenge in the case of opioids and mental health in that a surprising number of mothers will go to extraordinary lengths to stay sober during their pregnancies and to get clean for the sake of their babies. That gets compounded by the fact that in a lot of instances, appropriately, whatever they call it in the given state, in Massachusetts' Division of Children and Families, will come in and take the baby away at the time of birth, because unless there's some other support system within the broader family that can take care of the baby. And that plunges those mothers into even deeper depression. And we just had a regional maternal mortality meeting last week where we discussed the issue of, are there additional supports that will identify and then take care of those mothers who face multiple challenges. It's not a stretch to think that they would then go back to using and using intently.
And then this is Nina. So we wrote about a woman who was addicted to opioids, who died in 2016, and her story is really striking. She, as Dr. DeClercq mentioned, she had comorbidity. She was depressed. She had a history of depression that she really struggled with. She did everything she could to stay off drugs while she was pregnant. As soon as she gave birth, she always knew that the postpartum period was going to be difficult, but she was completely unprepared for how difficult it was, and there were no support systems. She was in a clinic. She was in a program, but she literally couldn't get there because she didn't have daycare, and she didn't have transportation. Her partner, who was fully supportive of her, worked all day, and he couldn't take her to these things. So it's those kinds of things that lead to these really tragic stories, and they have to be taken into account when you think about the big picture of why these women are dying of those problems in this period a lot of times.
One of the key issues that we haven't discussed yet is maternal mental health, and it's been a trickier one to analyze. We're doing a big review in California of suicides and substance abuse, and it's apparent that suicides, the rates actually fall considerably during pregnancy in the first 6 weeks compared to reproductive age women, and then they start to rise. They're still lower than other reproductive age women, but it is a major cause of death among young women, whether you're pregnant or not, and it is a considerably large number. The trick is identifying what's related to pregnancy versus not, but at the end of the day, it doesn't really matter. We need to do a better job of improving mental health services in this country, particularly in this time period. And we have opportunities because these women have been in the healthcare system and been seen a lot, but again, we're faced with reductions in care at 6 weeks post-delivery.
We have a question from Lisa Kleppel for Nina Martin. She says, can you speak more about how you went about getting medical records for your stories?
Most everyone we spoke to had access. I mean, everybody does have access. Most people have access to the medical records of the loved ones. I think that there were only a couple times when we spoke to mothers of women who had died, or the mother's side. Sometimes the husband had those records, and they had the right to those records, and the mother's side didn't necessarily have them. But we found that almost everybody had the records, because very often, if there was a maternal death that they felt was something preventable, if it had happened, if there was a medical error, they had at least thought about getting seeing a lawyer. So they had the records, and in some cases they didn't, where there wasn't an autopsy, or the autopsy hadn't come in, or the autopsy results were inconclusive. The family gets the medical records just because they want to know, they need some closure. And so in my experience, they were very happy to share those records with us. We keep them confidential. There's a lot of confidential information in them that we don't share, but we have not had any trouble getting medical records for our stories from people that we've asked.
And we have a question from Sean Hamill, who says, it sounds like ProPublica had a hard time tracking down data on the deaths, but California used death data. Do coroners typically or ever list anything on death certificates that would indicate the death was related to maternal issues? And what is the best way to find out about these deaths in our area or in states from official sources?
I'll let you guys take that one.
Yeah.
Yeah.
So a coroner's report we'll discuss in detail, but they're not filed in every case. Probably only about half the cases have a full coroner's report. Many times hospital deaths will not go to the coroner. I'm not certain that those are cleanly publicly available, however. They certainly go through the public health channels and are available there. The death certificates will have, one of the troubles with our statistics is that we were clearly underreporting for a number of years, and and to improve that, we added a pregnancy checkbox to a death certificate that would indicate whether she was pregnant the last 42 days or a year. That ended up creating its own set of problems when we're probably overcounting some of those deaths now with the pregnancy checkbox, where it was checked in error. I'm not really sure about the public availability of death certificates. I think they can be accessed, but it's I don't think you can search them. Yeah, I don't think
generally
it's easy to search either.
The short death certificates are public records. Birth records aren't, but death records are. But the coroner's reports, it's going to vary enormously. We're on the Maternal Mortality Review Committee in Massachusetts. We don't get the coroner's records. The coroner representative of the medical examiner sits on the committee and will read out the report, but it's not circulated. Now that's our state. Other states have different approaches to that. Yeah. But I don't think it's going to be publicly available very often for a reporter to get a look at.
No, I agree with you. We looked, and I mean, it's surprisingly unavailable in many states. So I think that as far as that's really why we ended up taking the route that we did, and I think that monitoring social media and also making it known in your community that you're looking for these stories is a way to find those stories.
I really like the idea, though, of looking at the near misses, the close calls. Mm-hmm. Then you have a lot more information to work with if you can do a direct interview, of course. And those are surprisingly similar when we've looked at and interviewed cases of near misses. The issues are very similar to those that result in death.
Yeah. We have a question from Carol Morton. How do we find state numbers for comparable rates?
So we work on this, my colleague and I, and we don't report state numbers because they're simply not reliable enough at this point. There was a publication last year that tried to do state numbers, and they presented state numbers, but they weren't really accurate. So it's at an individual level, you're going to have to contact states. But we get that question all the time of, which state has the worst, which has the best. And part of the problem is the fact that in a lot of the states, maternal deaths, we're talking a rate of say it's 15 per 100,000. In a state like Vermont that has 8,000 births, you're talking single digits at best in terms of getting those numbers. And so state rates are not available yet. They maybe in a few years when the data is cleaned up, that'll be a possibility. But as it stands now, you can perhaps get it for your individual state. You can contact your state's maternal mortality review committee. About 38 states have some form of a review committee. But there's not a single site you can go to where, well, actually there are sites that you can go to where that's listed. They're just not reliable.
The site that Jean's referring to is CDC Wonder, and that's just raw death certificate information. And it does have a lot of errors in it. We really like to look at deaths that have passed through the review eyes of a committee, or at least like the CDC surveillance group has physicians on it that are looking at accumulated data. Now, the CDC cannot provide state level data. That's not allowed under their purview to break it down to states. And so, California is the size of a European country, so we have sufficient sample size to be able to do that, whereas many smaller states just can't, unless you do rolling 3 or 4 year numbers, but even the smallest states, that wouldn't be appropriate for. But at the very least, I would look at trends over rolling 3 or 4 year averages, if you're looking at any state besides California, maybe Texas.
So I just wanted to let our participants know that our hour has officially ended, but our panelists have agreed to stay a little bit longer. So we'll take a few more questions here. There will be a recording available, video basically, of this whole series of presentations, and everybody's PowerPoints will be up as well. on our website, and we'll also be sending out a short survey, which we urge you to complete. It helps us with our work, but we're going to turn back to just a couple more questions here. We have one from Shannon McNabb, who has a question for Dr. Main. She says, how does the CMQCC work with community-based organizations to explore some of the social determinants that are playing a role in mortality and morbidity?
So that's a project that we're just starting right now as we're looking to move beyond the hospital, beyond the doctor's office into the communities. And certainly as you're dealing with issues such as disparity, you have to do that. And for some of the causes of death as well, you need to move beyond the hospitals. So we are working with a number of community organizations currently, but that's going to be ramped up in the next couple of years as we get additional funding to do that. So I don't have any secrets on that yet. I do think there are, we have the decline in maternal mortality in California was similar for white and black. So we had a 50% decline in whites, we had a 50% decline in black maternal mortality, but the ratio still was 3 times. So we had a good news that was improvement, but the bad news was we still had the disparity. So now we're going back to the drawing board and looking at a variety of different approaches.
We have a question from Trish Supli asking how can researchers, and I would say journalists too, look into near misses in their state?
This is Nina. I guess that's, so you could, I mean, again, I sort of, there's some states that are starting to collect data, I believe, on this. The problem is that data is all, again, pretty de-identified, correct? Dr. Main can speak to that, or Dr. DeClercq. I mean, basically what we have done is, I think it's a template that anyone can follow. What I did was, when I started this project, I started, basically, I reached out to many maternal health organizations. You have a slide, you'll have it on the PowerPoint. There are others as well who could be helpful, but those are the ones that I found to be particularly helpful. I was interested in finding, a broad range of women, and especially women of color, along with, and different complications, but you could be looking for women within a particular state or particular region. And then you just start talking to them. I think it's important, depending on what you're looking for, to kind of make sure that you reach out broadly. So don't just think about the region, but also think about the types of complications that women are suffering. Some organizations, Preeclampsia Foundation, I just want to give a shout out to, and the AFE Foundation, and there's a number of them on that list, but the Hope for Accreta and the Accreta folks, the National Accreta Center, I think it's called. I don't have that list. Anyways, they're all great, and they can help you fill in the blanks. You get a range of different kinds of complications, and but I think that you want to make sure that you do have a range of complications, that you're not just, unless you're interested specifically in preeclampsia or cardiomyopathy or something, you want to make sure that you are trying to get a bigger picture of what's going on, and then you just start talking to people, and they put you in touch with people. That's what we did at the beginning. So anyway, sorry, go ahead, Dr. Main or Dr. DeClercq.
Well, I think one of the important points you were raising is that maternal death is not a single entity. Women die from multiple causes, and each of those has a different pathway toward prevention.
Right.
For example, cardiovascular disease is really something that often happens months after delivery. We'll have a very different approach toward prevention, and that's where transition of care issues are going to be critically important.
We have a question from Juliet Garlow, who says, can any of the speakers comment on the recent rise in maternal mortality that's been noted in Texas recently?
I can speak to that some, because it was our paper that sort of sparked a lot of that. The confusion that happened as a result of the paper was as I noted, we were trying to come up with a national maternal mortality rate, and we went through state data to the extent that you could, and combined states based on some measurement issues. When we got to Texas, there was such an unusual pattern to the data that we didn't include them in our national estimate because we assumed there were data issues. And apparently there are. And so one of the things, I think the safest way to understand the situation in Texas is the data that we had suggested a massive increase from about 18 per 100,000 to about 34 per 100,000 between 2010 and 2012. Texas folks came back and said, we have other data that suggests the increase wasn't that great, but their data simply showed that it was not that great because they had higher rates earlier. But most every source I've seen, ours and the Texas data suggests that the rate is somewhere over 30 per 100,000. And that would put it in developing country ranges. There's also wide disparities in Texas, and so the Texas rate for non-Hispanic Black mothers is somewhere much higher than that 30. The reasons for it aren't clear. I did note one statistic about the Medicaid coverage in Texas is pretty rough in terms of mothers getting on and then mothers getting off. You will not qualify for Medicaid if you make more than 18% of the poverty level if you're not pregnant. And so while their coverage for pregnant women is reasonably generous at roughly the national average, their coverage for non-pregnant women is among the lowest, tied with Alabama for the lowest in the country. So that's a challenge in Texas. Now, Texas has a maternal mortality review committee. The chair of that committee is, I think, the incoming president of the American College of OBGYN. They're very committed to making changes there, but it's a real challenge. I'll note one other thing about Texas and the national data that tends not to get much attention, and that's the fact that the Hispanic rate in Texas is far lower than that for either Black mothers or white mothers. And the national rate is lower for Hispanic mothers than any other group. And in all the talk about disparities, I think the more positive message around Hispanic mothers is lost and needs to be part of the consideration of what's working there and what things help keep those rates low.
I think one of the lessons from Texas as well is the need for state-based maternal mortality review committees. It does appear that conditions and reasons may vary from state to state, and so it's super important to have your data be local and not just respond to national levels of data. And I think they're going to learn some lessons from that. I'm just hoping that they can turn those lessons into actions.
We have another data question by Ann Garrett, who says, can you speak to your ideas on how we can get better data on maternal mortality and morbidity? Is it via the CDC or NGOs? I don't know if you feel like you've already said what you can say about that, but just wanted to share that question.
I think Elliot noted appropriately that the CDC pregnancy-related mortality rates that get published are probably our most reliable source for national data. But by the nature of the agreements they make with the states who give them that data, they can't publish state rates. But for national trends, I would rely on their data more than any other. And if you want to convert that to a maternal mortality rate, it's not rocket science. Take that pie chart I used, and I showed you that showed roughly 87% of the deaths occurred from pregnancy through 42 days after, and multiply that by whatever national rate they have, and you'll get a pretty good estimate of what the maternal mortality rate is in the country. So that's probably the best source nationally. Again, at the state level, it might be an individual talking to your state Department of Public Health, which has some of the data. I'd be careful about using CDC Wonder. Again, that's a crude measure, and it doesn't necessarily account, unless you really spend a fair amount of time working with it and draw on some expertise, that's going to be a real challenge.
We have a question from Diane Forrester, who says she's working for a conservative state Medicaid department whose pregnancy coverage is geared to the child and not the mom. It's called the needs of the unborn. Since the moms don't really have coverage post-delivery, is there any kind of established member outreach to educate women on what to look for, particularly in hemorrhage and preeclampsia, so they can identify when they need to seek care, since no one is following up with them?
We are working on better educational materials. Some of our partner organizations like A1 have done a very good job of this. And so, but hemorrhage and preeclampsia are conditions that lead to maternal morbidity and death, usually during pregnancy, during delivery, or the first 6 weeks. The bigger challenge is some of the later causes of death, which would be cardiovascular disease in particular, and maternal mental health issues. And I think we can do a better job of alerting folks for those, but that still remains a work in progress.
From an advocacy perspective, I'd also encourage people to look at some of the stories in Nina's reporting about the impacts of the death of a mother on children. To the extent that people don't want to focus on mothers and only on babies, one of the best ways to keep babies safe is to keep their families together and their mothers there. And that has there's a lot of research internationally on the impact of maternal mortality. I think the work that ProPublica and NPR have been doing to document the impacts in the United States is important and becomes a key element in advocating to people who might not be open to that idea initially.
Thank you for that shout out. And I want to say again, patient advocacy groups, the groups that some of the groups that I've mentioned on that slide that you'll be getting, as well as others, are great. They're very, very, very dedicated to this issue. A1 and in particular, and also a group that's not listed there, but it's the Institute for Perinatal Quality Improvement, have a big project trying to improve postpartum education for nurses and for women in ways that are pretty simple and I think will be profoundly effective. And so there's a lot of organizations, patient advocacy organizations and quality improvement organizations that are trying to address these issues, and I think they're.
And we have a question from Elizabeth Aguilera, who says, what are the factors that keep the rates low among Hispanic women?
We don't have a good handle on that. A very important question. They actually do pretty well for many public health indicators in the perinatal realm. See pretty low, at least in California, very low rates of prematurity, very good outcomes for infant mortality. So it's speculation at this point. We think there's stronger family bonds, and family supports is one hypothesis, but nothing is really proven yet. There may be less substance use in that population as well, among the women in particular, but we don't have a good handle.
If you know someone who wants to fund a study along those lines, we've made that one of our next agenda items, because I think it's we focus so much on negative outcomes. This is an opportunity to focus on a more positive outcome. And there's many lessons to be learned from that.
We have a question from Kathy Leone. She says, I'm also interested in findings regarding spontaneous coronary artery dissections, and I'd ask anyone who replies to this to define this a little for the rest of us, which causes heart attacks and sudden cardiac arrest. We know families who've lost a new mom to SCAD. We know survivors who were dismissed at the ER. Can SCAD be a topic of interest for your study?
Well, this is Nina. So among the patient advocacy resources I've mentioned, the SCAD Alliance, exactly, because there's, as Dr. Main and Dr. DeClercq have mentioned, heart-related issues are such a big part, I think, of the causes of maternal deaths. often in the postpartum period. And in fact, we wrote about a woman, Amy Bartlett, who was the Yellowstone spokeswoman, who died of SCAD in 2016. So it's one of those conditions that is definitely on the radar of many organizations, of growing numbers of organizations, and there's resources to find those folks.
And our final question is from Robin Paoli, who says, what are the most impactful actions local health organizations can take to jumpstart statewide collaboration?
I think these advocacy efforts and all the news media attention on this, NPR has a wonderful piece as well that's archived on their site, is in having reporters knock on the doors of state and local officials asking what they're doing. We've had a number of referrals or of people saying, what should I be doing coming to us after reporters have knocked on their doors? So that's an interesting entree.
I think pressing the local officials about better identification of timing of deaths. I bugged the CDC people to get that data to come up with that pie chart that I was using, in large part because I think it's different messages. I think it's a message around pregnancy, a message around intrapartum care, and a message around postpartum care. And the combination of better data to be able to say we have a particular problem in this area around deaths during pregnancy is an important message. And that combined with, as I said, stories. You know, advocacy is around data and stories, both. And you need the empirical basis to make the case. But honestly, in trying to influence legislators and other policymakers, stories are at least as powerful.
I would agree with that, obviously. And I guess the thing I would say is I think the stories are really powerful, but I also, I think it's important to kind of think about what the stories are that you're telling as a reporter about this issue. And so I go back to one of the points I made at the end of my presentation, which is that I think that it's, you know, there's been a tendency when we've covered as journalists maternal deaths in the past, we talk about them as human interest stories. We talk about the sad mother who died. And, you know, sometimes it's really just about publicizing the GoFundMe or the YouCaring account. And I think to really, as a reporter, to sort of think about these, this topic as being a public health issue, and what is that, how do you report it in that way? And so while it's really important to tell the human stories, I think it's also really important to sort of always have in mind, no, wait a second, what is our policy around this? What are we doing? How do we learn from this? And that's one of the reasons I also want to say, I think it's really important not to just treat maternal deaths or near misses as being sort of merely anecdotal leads. You know, as reporters, that's what we often do. We kind of think we know the story, and then we go and we find the anecdote to sort of confirm our you know, how we want to present it, and it doesn't necessarily go very deep. And it's really easy not to go very deep in these stories because they're really painful stories, and you have to sort of, and they're often really complicated, and the nuance is really important. But if you don't, you miss the story. And I think that really being willing to kind of go down deep and not necessarily super long, it doesn't have to be 9,000 words, but to go deep and to really try to learn from what these families are telling you and what the near miss is really critical to sort of having that kind of impact. I think if you just think about it as being just, well, as a human interest or as an anecdote, it's not gonna do what you want it to do.
So I think the strongest approach is to marry data with stories, because they appeal to different parts of the brain, and then also attach it to what can you do, what can be done. That's you know, it's not a hopeless situation. There are things that we can do, and so that's an advocacy piece that's also quite important.
Right. And you're right. And I think that that's also the power of the stories, that we've done, I think has been not just the sad stories, although the stories have been sad, but there is, in that first piece about Lauren Bloomstein, they're clear policy. Oh, there's lots showing, well, it didn't have to be this way. And so the question is, why would any hospital or any, public system allow it to continue to be that way when it doesn't have to be that way?
Well, on that note, I want to thank our three excellent panelists for their time and for going over a little bit on our webinar, and to thank all of our participants for their excellent questions. We will be uploading a recording of the video of this webinar a little later today, and we'll be putting up everybody's PowerPoints. Thank you so much, and I hope this was useful.
Thank you.
Thank you.
Thank you, everyone. Bye.
Bye.